You're listening to the Talking Rheumatology Spotlight podcast, brought to you by the British Society for Rheumatology.
So we're here at the Case-Based Conference. It's September 2023 and it's in Liverpool. Today it's a Talking Rheumatology Spotlight on rheumatoid arthritis. My name's Stephanie Gall. I'm one of the Merseyside trainees in rheumatology. I'm joined today by Professor Chris Edwards, who's a consultant rheumatologist in Southampton and co-director of the NIHR in Southampton Clinical Research Facility. Thank you very much for joining us today.
Yeah, thanks for having me, Stephanie.
Thank you. I wondered if we could start quite broad with the topic and chat about your overall approach to the management of patients with rheumatoid arthritis.
Yeah, we're at a really interesting time for treating rheumatoid, aren't we? We've had lots of years of development.
Yeah.
You know, if I reflect back to when I was a medical student, then people with rheumatoid had often terrible disease, and a lot of the energy that we employed was about dealing with disability, occupational therapy, aids for people. Then we've moved through a development of medications like cytokine inhibitors, starting with the TNF inhibitors, then a plethora of other targets, now signaling molecule inhibitors. Yeah. And on top of the therapies, different strategies. And the strategies are as important, I think, as the drugs.
Yeah, absolutely.
And probably also there have been changes to our patient population in relation to much less smoking, much less industrial dust exposure. Yeah. And all of those have probably made disease maybe a little bit less aggressive.
Yeah.
So, you know, really interesting time. And now it's the fine-tuning time there to try and work out how we approach an individual and say, you need this medication, or you need a different medication. Your risk profile is this. Yeah. And that's the real challenge at the moment, I think, with what we're doing.
Absolutely. And with the fine tuning, is there, because it's difficult, isn't it, when we've only got a certain amount of time in clinic and there's a lot of factors to consider. Is there a certain approach you take to the fine tuning?
Well, I was thinking about when you were asking the question about a general approach.
Yeah.
That I think sometimes generates time. Now, everybody has a different way of doing this, and so I wouldn't want to say this is the way to do it. But in my mind, with all of patients with rheumatological disease, I guess medicine in general, it's about thresholds, isn't it? It's about crossing a threshold. Every patient I see, if I haven't seen them for a bit, if someone else has seen them, have I crossed the threshold where I'm certain it's rheumatoid?
Yeah.
If I'm certain it's rheumatoid, how certain, and is it likely to be bad rheumatoid? You know, rheumatoid factor positive, anti-CCP, erosions already. And then you're crossing the threshold. Is it bad enough I have to do something? What's the DAS28 score? Yeah. And for me, if I think in thresholds, you can actually get to those much more quickly than going through everything, collecting all the information. And that helps me to also then have the time to have the discussion about how someone's feeling and how their mental health is and those other bits that often get squeezed out. So I'm not sure if that completely answers it, but in my mind, that kind of threshold, reaching these thresholds makes it much easier for me to practice, I think.
Yeah, it kind of explains the importance of getting to know your rheumatologist and getting to know your rheumatology team as well, because it does become difficult when you're seeing different people and various people are seeing the same person. The fine tuning, I think, definitely comes from.
Yeah, and I think it's nice to have that relationship in one. But I also think it's nice for people, and of course, a patient's view on this would be much more important than mine. But it's nice to be in a situation where people do see someone different, brings a slightly different thought process. It's easy to see someone for years and to get a bit relaxed as the clinician and go, I know this person.
Yeah,
they're doing
I see what
fine.
You mean. Yeah.
So a little bit of stuff that shakes up what you're doing, that changes, that questions whether you've done enough. I think that's also useful, which is why I think the opportunity to see trainees, the opportunity to see our specialist nurse colleagues, the opportunity to see physiotherapists, all of that becomes important in just nudging a slightly different approach, I think.
Yeah. One of the things I'd like to talk about is sometimes you get patients who may be having quite bad flares of rheumatoid arthritis and aren't necessarily keen to go on the next step just because they don't necessarily know that much about it. How do you approach that?
For me, it's about giving people the full story of the risk and benefit.
Yeah.
We spend a lot of time telling people about risk and I guess medical legal concerns, worries about getting it wrong. Wanting to do the best for someone means we tell them these are all the side effects. These are the adverse events. Here's the booklet of the adverse events. But we really need to show the flip side and say, but untreated, these are the problems, without being dramatic and trying to scare someone, and to have both pages of the book open at the same time. This is the good, this is the bad. You know, an example of that is we immunosuppress people. We give them a risk of infection. We tell them about that risk, but uncontrolled rheumatoid gives a risk of infection as well.
Yeah.
And we really understood that through COVID. Some of the data really showed that as well, made that clear in our mind. So it's sharing sharing that balance with people. It's good and bad when we do things.
Yeah, absolutely. Speaking of the risks of rheumatoid, I wondered if we could speak about the cardiovascular risks of rheumatoid arthritis.
Yeah, so me, really interesting area. I guess as a personality, I get bored easily. And so it's always interesting to look at where we touch against other specialities. And I've had, great fun, lots of interest, been educated really well by colleagues in interstitial lung disease, for example, cardiovascular physicians, dermatologists who come and do joint clinics with us, renal physicians. So those edges are always fascinating just because they're edges.
Yeah.
And we learn from slightly different approaches of colleagues who are all physicians, but have just a slightly different way of doing things. The cardiovascular bit is interesting. Deciding how much of the time we spend controlling the statins, how much of that should be done by general practice, which is under enormous pressure at the moment.
Yeah.
And how much of it is just about controlling inflammatory disease. There was a very nice abstract in one of the sessions I was in at EULAR recently, where a group had looked at the risk of cardiovascular events in people who achieve remission on conventional synthetic DMARDs or biologics. And actually, when you achieve remission in those groups, the cardiovascular risk goes down to normal in the population. Now, that's one study, but my bias is always, it's inflammation. In fact, I heard Patrick Kiley at 10 Topics he spoke this year, and Patrick was talking about the fact we're inflammation doctors. That's the bit we know.
Yeah.
And those are the tools we have. We're really good at doing that. Turn off the inflammation. Many of the things that are comorbidities will become better.
That's really interesting. It alludes to the importance of a multidisciplinary approach as well to patients with rheumatoid arthritis.
Yeah, and also being realistic about what we can do.
Absolutely.
We can overwhelm people. If you think the first time someone comes to clinic and you diagnose rheumatoid, you might start them on methotrexate, steroids, maybe hydroxychloroquine, perhaps a bit less now. You might give them bone protection. You might give them a statin. There's a whole, and you have to decide which bit you're going to target so that you don't overwhelm people, I think, as well. Get that balance right.
Absolutely. When you're managing a patient with rheumatoid arthritis, how quickly would you consider changing treatment if somebody's not responding? Is it immediately, or would you give it a bit of chance?
Yeah, I think. Well, I suppose it depends a little bit. So when people are in terrible pain and have lots of inflammation, perhaps at the beginning, then you need something to work really quickly. Yeah. And I guess that's still why we use steroids. Controversial area about where you use steroids, but it does switch things off very quickly. And I don't have access to a biologic that I can give immediately to switch it off in that way. But in general, when we're using DMARDs, we need to leave them a bit of time. If you look at what the EULAR recommendations say, they would say we want a response by 3 months and we want to achieve the target by 6 months.
Okay.
Now, I'm much more impatient than that. I'm trying to make it quicker, but probably over a lifetime of disease, that approach stops you switching too often because there is this danger. Patient doesn't like the drug. We don't think it's working. Swap, 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 swap.
Yeah. And
suddenly you've used 6 or 7 things and then you end up having to go back to the beginning and then perhaps do it properly and take a bit more time working out why things didn't work.
Yeah. Speaking of the glucocorticoids, I know there's been a bit of controversy recently with the ACR and EULAR guidance. ACR essentially saying don't use glucocorticoids or use them as little as possible. What's your thought on glucocorticoids?
Yeah, I'm caught between the two. I think I'm from a generation of rheumatologists who was trained by a generation of rheumatologists who had used high-dose steroids and seen what terrible things high-dose steroids are, not just in rheumatoid, but in lupus and other diseases as well. And so we were all taught to use as little as possible to reduce doses. So that's very much in my mind. But also the reality is that steroids make people better very quickly. And there's also those nice bits of work that people like Martin Bors has produced with the Gloria study, which kind of nudge you to feel a little bit more confident. I'm sure you've come across this study. So these are people over 65 with rheumatoid, already on other DMARDs, and they get 5 milligrams of prednisolone or not. And those people, in terms of their disease activity, do better. Their bone density is a little bit less, although the fracture risk over the couple of year study wasn't more. And little bits of that were presented at EULA, extra post hoc analyses. For example, those people put on weight. One of the things we might be concerned about with steroids is the BMI going up. But when they looked at which bit of weight, it was lean muscle because they were able to do more. So there is this tension, but personally, I think it's unrealistic to not use any steroid. I think you just want to use a little bit for as short a time as possible. But sometimes when you're in the 5 milligrams and less per day, the risk is so relatively small. And if someone feels so much better, I think pragmatically, I think I'd use it.
Yeah, that sounds reasonable. And what point would you say putting people on a low dose steroid? Is there a certain point if...
I think there are 1 or 2 people, we try not to do this, don't we? But there are 1 or 2 people who just never get off. They just always feel better. And I'd like them to be off. But if it's less than 5 milligrams, if it's 5 milligrams, maybe I accept that.
Okay.
And then there are some people, perhaps this happens a little bit more as people get older as well, where they might not want to change to a stronger drug. You're trying to manage their symptoms, and it just becomes easier to use a small amount of steroid. You know, I'm conscious of the fact that as a result, we may not treat older people as well as we should. But there are complications about treating people as they get older, which we have to weigh to try and decide, you know, symptoms versus side effects versus adding another DMARD.
One of the things I wondered if we could talk about is JAK inhibitors, because I know there's been quite a lot of controversy around that at the minute. What are your thoughts?
So, you know, here was a class of drugs with really good efficacy, at least as good as TNF inhibitors. Some studies showing a bit better. Oral tablets, really short half-life. So they work quickly and they get out of the system quickly if we have any problems. And then you have this grey cloud above them saying, in some studies, particularly, of course, the oral surveillance study for tofacitinib, is there a little bit more cardiovascular disease? Is there a little bit more malignancy? Is there a little bit more DVT, pulmonary embolus? And as a result, I think quite reasonably, all of the regulatory authorities around the world say, be a bit careful in those people at risk. And I think that's changed what I do a bit. Probably, in terms of what we do, certainly in Southampton, we were largely putting people as a first advanced therapy onto adalimumab biosimilar. And that's partly because it works. We know a lot about it, and it was cheap as well. Cheap doesn't mean bad. It was just that was another driving force. So we were often using JAK inhibitors a bit later in the pathway when perhaps that risk benefit is in favour of using it. The other thing to reflect on, I think, is there's more data to come, although I suspect it will remain a bit grey over time. We may become more comfortable with how we manage it. We're already selecting a lower risk group probably, so perhaps over time the signals will become less scary. And the last thing for me to reflect on is if the regulatory authorities thought this was a very scary thing, they would have stopped us being able to use these therapies rather like they did for the COX-2 inhibitor Vioxx, decade plus ago. And so I introduce a bit of caution into my thinking, but there are patients who failed other things who need a way out. And there are some people at low risk who just want to have a tablet. And I think that's fine. So I think my practice probably hasn't changed so much. I'm probably a bit more cautious because we were already using JAK inhibitors a bit later because of using a TNF inhibitor first.
And did you get many patients that were already on JAK inhibitors that said, actually, I don't want to have this anymore? No. And I don't know whether that's because the information isn't largely in the public domain in a way people feel comfortable about. It doesn't seem to have caused concern. Maybe it's the group of people we'd put on are already a little bit further down the line and needed something. And just something for me to remember and reflect on is, as part of producing the EULAR recommendations for treating rheumatoid,
We sit in a steering group, then in a task force. There are patient representatives there. And the patients, when we are writing the bit about safety in relation to JAK and sequencing, where does TNF go, where do JAK inhibitors go, said, we want to know about the risk. We can see that there's a potential risk flagged up, but we want to have drugs available so that we can make the decision and the clinician can make the decision. So, yeah, I want to have them available.
Yeah, absolutely. It shows the importance of discussing with the patients as well. And
yeah, it's a shared decision.
Yeah, absolutely.
And that can sound like a cliche, but it really is.
Yeah, it really is. And I suppose when patients have got maybe they're getting quite far down the line and a treatment is working for them, they'll accept sort of a slightly increased risk.
And I think that's reasonable, isn't it? The more severe a disease is, the more reasonable a risk is to take.
Absolutely.
But milder at the beginning, someone with loads of risk factors who's had recent breast cancer and has had a myocardial infarction, you're going to go, no, that's not the right person.
Okay, lovely. One of the other things that I'd like to talk about is rheumatoid arthritis and the brain and inflammation, if that's okay.
Yeah. So I think this is a really interesting area. So my route into being interested in this was the cardiovascular side. Systemic inflammation driving early cardiovascular disease. And although rheumatoid became a really good example and lots of studies were done, it's probably true of all systemic inflammation. And then you get the stories around systemic inflammation driving depression and anxiety, and how much of depression is driven by inflammatory cytokines. So that becomes interesting. And then I bumped into a colleague in Southampton called Clive Holmes, who's a dementia expert.
Okay.
And Clive was doing some work that showed if you have a cohort of Alzheimer's patients, if they're exposed to acute inflammatory insults like infections, their Alzheimer's gets worse and they deteriorate more rapidly. But if they're exposed to a chronic inflammatory insult like rheumatoid arthritis, it gets worse much more quickly. So Clive became interested, started being interested in could they use inhibitors of TNF, for example, to start to treat Alzheimer's, and he's been involved in some phase 2 studies. And around the same sort of time, we were using the CPRD, General Practice Research Database as it was called, to look at cardiovascular risk. And we also looked at dementia in relation to methotrexate. And so there's a little bit of work that shows that patients with rheumatoid or methotrexate have less dementia. So you start thinking, that's pretty interesting. Colleagues at Oxford used the same data set and took it a little bit further. They divided them up into, I think they were tertiles of exposure to methotrexate and dosing. And there was a dose response. So the more methotrexate, or the longer you're exposed to it, the more the protection against dementia. And they looked at other disease-modifying drugs like sulfasalazine, showed it wasn't there. So that's pretty interesting around methotrexate, and it's sort of the cardiovascular story is similar.
Yeah.
And then there are these big health outcomes databases in the United States where people have looked at dementia in relation to TNF inhibitor use. And TNF inhibitor use seems to be associated with less dementia. Now, none of this proves anything. It's epidemiology. It nudges you in the right direction. But that leads to things like the RESIST study that we've been involved in. Alzheimer's Society funded this. Colleagues in Queen's University in Belfast led it. And we recruited patients trying to look at the effect of disease-modifying drugs on cognitive function scores in patients with rheumatoid. So I think that's a really interesting area. And then, forgive me, I'm probably going on too long talking about this, but Neil Basu in Glasgow has got this lovely work where they've scanned brains, MRI, structural and functional scans, and show systemic inflammation changing the structure, function, and neural networks within the brain. And that becomes really fascinating. We treat people, their joints get better. They often continue to have fatigue and brain fog. Is that some sort of emotional response, or is there rewiring in the brain that's gone on that needs a different approach to treat it? So, yeah, as you can see, I think it's a fascinating area.
It's really interesting.
It's like an ocean. It's like the deep oceans, isn't it? We don't understand everything.
Absolutely. That's really interesting research that's going on. Do you find a lot of your older patients with rheumatoid arthritis have dementia? Is that something that have you noticed?
It's not. There are some meta-analyses, some systematic literature reviews where people have looked at cognitive dysfunction in rheumatoid and suggest there is more cognitive dysfunction.
Yeah.
I'm not sure I would have known that from my clinical experience. But what the RESIST study, the study I was just mentioning with our colleagues in Belfast, is when you look at mild cognitive impairment, you can use something called the MOCA score, Montreal Cognitive Assessment. And you can say, okay, I'll pick the lowest within the normal range, the lowest tertile. So mild cognitive impairment, not dementia. And that was the screening tool that was used to allow people into the RESIST study. And actually a really large number of our over 55 patients with rheumatoid fall into that mild cognitive impairment, more than the general population. So I think there is more than we think. Now, it's not just dementia, it's pain, it's not being able to sleep, it's depression and anxiety. But I think there is probably more mild cognitive dysfunction in chronic disease in general, particularly inflammatory diseases like rheumatoid, than we think. And that has implications for understanding the effect of inflammation on the brain, how we treat people, but also making sure we're explaining things to people really well. They have written material, they have other resources, so that they're, we're not leaving them not understanding what we've said.
Yeah, absolutely. The number of patients who, I try and give as many written resources as possible, but the number of patients who come into clinic and then the next time they're explaining something, you're thinking, and it's
scary seeing the doctor, isn't it? For all of us.
Yeah, absolutely.
I don't know about anyone, when I sit there, my heart's going, and it's just a weird scenario, isn't it?
Yeah.
So it's hard for people. And then if they've got mild cognitive impairment as well.
Absolutely. And certainly when you're speaking about risks of diseases and lots of medications, it can be quite overwhelming. So I think it is really important to give written information as well. And you do see a lot of our patients that complain of things such as brain fog that you might put down to the
I'd love it if,
fatigue
wouldn't it be interesting if, Neil Basu's type scan work, if that's an explanation for some of brain fog?
Yeah, it'd be really interesting.
And then you think after COVID, now long COVID is a slightly controversial area, but clearly for some people, things happen to their brains. There's a story around microvascular infarcts, which led some longer term problems for some people's thinking. Now, is that similar to many inflammatory diseases? I think that's that's fascinating.
Yeah, really interesting area. I wonder as well if we'd be able to talk about rheumatoid arthritis and interstitial lung disease.
So interstitial lung disease, I think, is interesting at the moment because now we've got some extra drugs. We've got some antifibrotics, and there are a number of our diseases in rheumatology that have problems with fibrotic components of the disease. Costantino Pizzalis in QMUL in London has done lots of wonderful work looking at histology of joints and showing that a resistant group have fibrosis. A resistant group of rheumatoid patients have fibrosis within their synovium, fibroblast driven. So we may need treatment for that. Then there's scleroderma. And then there's interstitial lung disease in all our diseases, including rheumatoid. And now with nintedanib, pirfenidone, maybe, we have an opportunity to be able to treat those things. And because of that, we're going to start looking more and finding those people more and trying to decide how big a problem it is. I'm lucky enough to do an interstitial lung disease clinic with one of my respiratory colleagues. And once again, this is one of these edges of rheumatology where we can learn a lot from our colleagues, looking at those HRCTs again and again, weighing up the pulmonary function test. But yeah, I think an interesting time to think at how do we find those patients and where does nintedanib fit into treating our patients with fibrotic interstitial lung disease.
Thank you so much for speaking today. And I just wondered if you could go through sort of the key learning points from this podcast.
So for me, seeing people early, the strategies that we have, this treating to a target, but don't get caught up into pushing too hard, and try and be thoughtful about how much of it is driven by inflammatory disease. We have really good drugs to treat that. But sometimes when we see difficult to treat rheumatoid, there are other factors. There's fatigue, there's depression, there's anxiety, and that might need a different approach. So I think that bit's important. Think about the effect of inflammation on the brain and cognitive function and depression. And then the other thing is to look out for those interstitial lung disease patients, because now we have antifibrotics, talk to our respiratory colleagues. And I guess as a general thing, we're often physicians as rheumatologists that interact with lots of other physicians. Yeah. Some people might call that we're translators of, between different medical specialities and encouraging that in all the things that we do. And I've mentioned that around neuroscience and interstitial lung disease and respiratory medicine particularly, but it applies to lots of other areas as well.
Lovely. Thank you so much for speaking today. Really appreciate it.
Thank you for listening to Talking Rheumatology Spotlight, brought to you by BSR. Please do rate, share and subscribe through your favourite podcast app.